So, hello to everybody and a warm welcome from Germany, Cologne. It's a pleasure for me and my esteemed colleague Alexander Volz to give this talk about the use of HD IVUS in modern PCI. And what we want to answer with this presentation is the question, why don't we use intravascular imaging as our default strategy in modern PCI? And maybe I can add already in almost every patient undergoing coronary catheterization with a significant amount of coronary artery disease. Just a brief introduction. My name is Hammerstingl. I'm an interventional cardiologist, of course. I work here in the hospital, in the Eduardus Hospital in Cologne since 3 years. And in my former career, I would say 20 years in the University of Bonn. And I'm happy to have on my side Alexander Volz, which is a specialist in interventional cardiology from Bonn. And we work together now since 2 years. And he took over the cath lab and is responsible for the cath lab since he is here since 2 years. And we have this talk with a short introduction concerning the theoretical background, a short overview of the current evidence, and then we have plenty of cases that we want to discuss with you.
Hi to everyone. Looking forward to a nice webinar here.
So if it comes to imaging of coronary stenosis, I think every one of you will know that there are several different imaging modalities that we can use and that are used in daily clinical practice or routine. And of course, every imaging modality has its place in an interventional workup of patients. We want to focus here on intravascular imaging, which is, of course, different from hemodynamics. And maybe we can discuss this issue in our live cases or in our recorded cases. But if it comes to intravascular imaging, I think there are some important information that we want to know in every our patients. And very important is that we want to rule in patients that benefit from treatments, especially if the stenosis that we see in our coronary angiography has a prognostic impact on the patients. And of course, and which is, in my opinion, even more important, we have to rule out patients that do not benefit from interventional treatment and in which maybe the treatment itself poses the patient as a certain risk depending on interventional strategy. And what is the benefit of intravascular imaging is to improve the safety and quality of interventional strategy and to foresee or determine the acute and the long-term success of PCI. And we want to briefly go over certain steps how this can be fulfilled by the use of intravascular imaging. Just to take a few steps back, why are we sometimes fooled by an ordinary, I would say, coronary angiogram? And those are very old data heading back to 2013, where they compared anatomical specimen with interventional outcomes. And what we see, and this is what they saw in those patients, is that angiography alone has a good specificity and sensitivity to predict a significant coronary artery disease in patients with relevant stenosis of the proximal large arteries. But the more complicated the coronary artery disease is, the less predictive is a coronary angiogram. And especially if you have very complex lesions, the angiogram alone was not very specific to predict relevant coronary artery disease. If we compare different intravascular imaging modalities. Every modality has a certain strength and weakness. And what is the advantage of the use of intravascular IVUS? We have a vast of extensive clinical experience with this method. It allows a deep penetration into the coronary artery wall, and compared to OCT, which of course has a high resolution, I can say it's more easy to use in daily clinical practice. It's really fast and accurate. You can use it, I would say, like an echocardiogram that you're using every day in your patients for if you do transthoracic echocardiography, and you can repeat the imaging and so on. And this is, to my opinion, one of the most important advantages of intravascular IVUS. You don't need to use additional contrast dye and so on. But I don't want to focus on to compare those different imaging modalities, and we want to focus on the following slides on intravascular IVUS, and especially on HD IVUS, which was, to my opinion, one major step forward. If you compare the newer platforms with older platforms, if you see the image quality, how to delineate the borders of the vessels and so on. So how far are we today? This is analysis from North America, from the US, I would say, which accounts even for European states. If you compare how many patients are treated and how often intravascular imaging is used in daily practice, you see that I would say in one of the most accepted indications, if you treat left main disease, only in 30% of patients, intravascular imaging is used to treat those patients with PCI. And if it comes to other disease, if you talk about multi-vessel PCI, the use of intravascular imaging is, I would say, relevantly underrepresented, despite a clear signal from the current guidelines. And this didn't really change over the time. If you look on data from 2014 to 2018, you see an increase of the use of imaging, but it's not huge. It's from 13% to 16%. And this is a clear signal that it's underused in daily clinical routine. What are the reasons why intravascular imaging is underused in daily clinical routine? I would say there are some prerequisites which are not really true. If we talk to our colleagues, they always tell us it's time-consuming, it's difficult to use, the measurement of the parameters is sometimes not clear. There seems to be some economical constraints, which are definitely not true, at least in Germany. And maybe it's due to the fact that in daily clinical routine, this is what I see in our cath lab, that some of the colleagues are simply, I would say, somehow impatient. And this is the reason why they don't use intravascular imaging if they have a coronary angiogram already. And they treat the patients, I would say, despite the fact that in some cases the patient does not need treatment. And what is really true, if you look into clinical evidence, is that imaging in PCI by the use of HD IVUS is easy to perform, especially if you use this in a daily clinical routine, if it's already implemented in your clinical routine in your cath lab, and which is even more important, if you look in centers who use it frequently, like we do, we see that it's not only contrast saving, which is of relevant importance in, I would say, 50 to 60% of our patients, but you can also save time, because you have in a very fast time a relevant, a perfect, I would say, overview of the extent of the disease. You can plan your procedure perfectly, and you don't need additional angulations from the angiogram to estimate the total amount of coronary artery disease in every patient. And this has been shown already 10 years ago in this small study, the Mozart study, which was a randomized controlled trial, and they found that the utilization of IVUS was safe and it reduced the volume of contrast dye compared to angiography alone. And this is, if you want to take it to an extreme, we don't do it routinely, but it has been reported from other centers that if in patients with severe renal failure, that you can complete a complex PCI even completely without the use of coronary of contrast dye, or by limiting the use of coronary of contrast dye to only 5 or 6 milliliters. And this is, I would say, the clear advantage of intravascular imaging. But if we should not only talk about how you can use spare time or contrast, but of course it's important to think about the patient outcomes. And this is, I would say, one of the most important aspects of the use of intravascular imaging. The ADAPT-DS trial, the cohort looked how the use of intravascular imaging might have an impact on clinical outcomes, and there's a clear signal, or there are several important messages from this trial. And the first one, and I would say this is what we see, and this is why we use IVUS in almost every PCI in daily practice. If you use intravascular imaging, then you will see that you change your treatment decision in a significant amount of your patients. In this trial, the use of intravascular imaging led to a change of treatment decision in 2/3 of every patient that has been treated. And it's not that the patient received a stent or not, but what is more important, that you adapt your strategy concerning the length of the lesions, and more importantly, how to decide how big the stent has to be to cover the lesion and to treat the patient with good outcomes. And if we talk about outcomes in this study, over time, this led to a significant reduction of myocardial infarction, stent thrombosis, and other relevant outcomes in patients with coronary artery disease. This is another study, 2-year follow-up of the same cohort, which showed a constant benefit of patients treated 2 years before by guidance of intravascular imaging. And meanwhile, this has been reproduced in other trials, like the Ultimate trial, which was a randomized comparison of IVUS-guided interventions versus angiography-guided interventions. And you see that there's a constant message from all those trials that if you use intravascular imaging, you have significant low rates of target vessel failures and stent thrombosis over time. And this is not only a short-term effect, but it translates in long-term outcomes if you follow up patients for over 3 years. And if you make a look into this meta-analysis with comprising more than 5,000 patients, if you pool those data, there's a clear signal that it's not only about, I would say, technical success, target vessel failure, but this, of course, if you treat enough patients, you will have an impact on mortality. And you see that if you pool those data, and I think this is true in daily clinical practice, that you have a significant impact on cardiovascular mortality. And this has been reproduced in several smaller trials. And this is a clear signal from this larger trial. What is very important, if we think about when and how to implement the strategy in our cath lab and who should use intravascular imaging, and this is has been published this year from a Korean group. It's very important that if the more less experienced the operator is, the more benefit he will have by using intravascular imaging. This is really, I would say, a clear message that you should not restrict the use of intravascular imaging to the experienced operators, that everybody entering the cath lab, starting to doing PCIs, should learn how to use IVUS, because those colleagues will benefit the most from the additional information that they get about the anatomy or the pathological findings, about the plaque extent, the lesion diameters, and so on. And this can be clearly seen with IVUS. And this is a clear message that it should not be restricted to experienced operators alone, that this should be routine use of intravascular imaging in every cath lab, especially by non-experienced colleagues. So this is when I want to hand over to Alexander, because if we now go into more detail concerning the guidance from the EuroPCI and so on, I think it's clear that IVUS should be used in complex situations. And there's always an ongoing debate if we must have it available also in non-complex situations, like I would say this coronary angiogram on the right-hand side. But I think we will show you some mind-blowing or maybe interesting cases which give you time to consider why not use IVUS in daily clinical routine in almost every patient. And so I leave this now to Alexander, who will give you a brief introduction on what you have to see, what you can expect, and then we will go through cases.
Okay, thank you very much. It has been shown in the first part of the presentation that the use of intravascular imaging by IVUS or other modalities paves the way to optimize results and better outcomes of our patients. The question, though, is when and how should we consider the adjunctive use of IVUS? According to the consensus paper published in 2018 by Lorenz Räber, it is a consensus opinion that IVUS should be used, for example, in angiographically unclear, ambiguous findings. Of course, left main stenosis assessment is an important role of IVUS, as well as other complex bifurcation lesions and so on. So far, randomized controlled trials have shown a benefit of using IVUS versus angiography-guided PCI, especially in long lesions and also in CTO situations. But also acute coronary syndrome patients can benefit from the use of IVUS, and of course patients with renal dysfunction to save contrast dye, as Professor Hammerstingl already mentioned clearly. But also the identification of mechanism of stent failure is a very important part of performing intravascular imaging, or a very important situation. We want to address and find out whether there is significant restenosis and stent thrombosis, which you're not able to identify by mere angiography-guided PCI. What is the goal of assessing a post-PCI result? On the right-hand side, you can see that our goal is to find a landing zone with a plaque burden below 50% at the stent edge. And of course, you have to consider the identification of lipid pools, because you have a very high probability, almost a guarantee, that if you stent into a lipid pool, that there will be dissection or vessel injury. So make sure having a fairly healthy landing zone. Also shown on the picture is that you have to make sure that you avoid malapposition and make sure that you achieve a good MSA, minimal surface area of minimum 5.5 millimeter square. Not only chronic coronary syndrome patients benefit from intracoronary imaging, also shown here in this flowchart, acute coronary syndrome patients are a very important patient cohort that benefit from the use of IVUS, for example, or OCT. As you see here in this flowchart, a very central role. You have a patient with an obstructive CAD, but with ambiguous angio, you do not really know what you're facing on the angio. You have to go forward and perform intracoronary imaging, as well as patients where you really don't find a stenosis, so non-obstructive CAD. There are some changes in the ECG. You have some pathological findings in the echocardiography and a angio ambiguity. Please perform intracoronary imaging. You will definitely have a better outcome of your patient. In an ideal world, how could this look? You perform an angiogram in 2 orthogonal views. You perform physiology if necessary. You perform intracoronary imaging and you identify certain challenges that you're facing anatomically. You can really plan your strategy really well. You can plan the sizes of your balloons, the probable stent sizes, and also modification such as atherectomy or IVL. After the verification by IVUS, you then proceed to stenting and post-dilatation, and very importantly, you shouldn't be satisfied with your angiography. You should always consider the IVUS optimization, because you will be surprised by many findings that you wouldn't have foreseen, only judged by the angiography. A very simple approach is very important. You shouldn't be doing a very complicated workflow. I really strongly support to do it as simple as possible, and in order to make it quick and smooth. But please make sure that you start imaging at least 20 millimeters distal of the lesion and continuing to the ostia to make sure there are no problems faced that you wouldn't have seen in the angiography, for example, in the left main. Then it's important to do lumen measurements, the distal part, the proximal part, the distal and proximal reference diameters, and then define your strategy. The lumen, the leading edge of the intima, is important here. You can see how to measure the diameter or the minimal lumen area. It's a very simple approach. The use of distal lumen reference is a very straightforward approach to safely apply. This is an example how to measure the so-called EEM, the external elastic membrane. When you use this mean EEM, you should take your sizes and then rounding down to the nearest stent size. Whereas if you apply to use the mean distal lumen diameter, you should be rounding up 0.25 millimeters. For example, a 3.76 mean distal lumen diameter would mean a 40 millimeter stent, for example. As far as the qualitative check is concerned, of course, this is not exactly the strength of IVUS. You have to be fair. In comparison to OCT, OCT is far more easy to interpret in certain situations, but especially compared to 20 megahertz, the HD IVUS with 60 megahertz enables you to identify certain pathologies with confidence, such as neo-intimal hyperplasia, as you can appreciate on the left-hand picture, or eccentric fibrous plaque or calcified plaque. The strength, as already mentioned, is that it is really penetrating to the adventitia, in contrast to the OCT. So you do not have the tendency of underestimating of the real size of the vessel. In addition, IVUS can also be used for assessment of extent coronary dissection and differentiation between true and false lumen, which is a very important aspect. So after having done a very quite theoretical part, I would like to proceed by showing you a few, I think, very nice cases which depict the importance of the really generous use of HD IVUS, and do not rely on your angiography alone. Of course, there are settings where you can leave intravascular imaging aside, but I would strongly advise you not to trust your angiography fully. In this patient, the 58-year-old male who presented with unstable angina, he had apical hypokinesia, and as he said, and we couldn't find out for sure, a few years ago he has been treated with a complex LAD diagonal stenting, as you can appreciate on the picture. Clearly, you can see a very tight stenosis in the medial part of the LAD, which we then addressed by choosing a NC balloon 3.0 by 8 millimeters. And as you can see on the left-hand side, the balloon gets dislocated proximally. There's some dog boning that you can appreciate. And honestly, in this patient at 50 years old, with really no native sclerosis, I wouldn't have foreseen this behavior of the balloon. And then we proceeded with HD IVUS. You can see the probe here, which is introduced. This is the transducer region. And as you can see, on the left-hand side, on the moving image, it's far more easy to recognize than on the still frame that there is a very tight stenosis in the medial LAD due to a neo-intimal hyperplasia. There's no calcifications, maybe some fibrosis. And then since an NC balloon didn't do his job, we then chose to proceed with a cutting balloon 3.0 by 13 millimeters. And then the final result after stenting, you could have probably also considered a DEB was this, but then we were wondering, is this really the final result? Because in the proximal part, proximal to the diagonal branch, which we angiographically underestimated, you can clearly see that there is intermediate stenosis of the proximal LAD, also caused by a neo-intimal hyperplasia. And would you treat this or not? That was the question. Should we perform additional FFR? Should we perform IFR? Due to the location of the stenosis and the intermediate degree, we straightforwardly decided to treat this lesion. But could we, based on the angiography, can we confidently treat this lesion? Because there is a very large diagonal branch just really shortly after the location of the stenosis. And what we did is very simple. We took a look at the HD IVUS. We measured the distal reference diameter right proximal to the side branch ostium, and checked the proximal reference diameter. And we came to the conclusion that an 8 millimeter stent by 4.5 would perfectly fit in this setting without jeopardizing any side branches or the proximal LAD. And then we performed stenting and achieved a very nice angiography and also HD IVUS results. I don't think we would have been able to really confidently do this without the use of HD IVUS.
Yeah, Alexander, maybe I just briefly interrupt you. So I think this is a very good example on how IVUS helped to understand the lesions better, because this was not a situation due to stent underexpansion, but neointimal hyperplasia. And of course, you feel much better if you really understand what happened, and then you chose your strategy than just by looking on an angiogram. Firstly, and secondly, I would say the proximal lesion alone, even if you perform maybe FFR measurements, I would say you can sometimes be fooled, because you only with this intravascular imaging, you really estimate the absolute amount of restenosis, which was huge, I would say, in this patient. And if I think nobody would have implanted a 4.5 millimeter stent in this proximal LAD. And this is the advantage of the intravascular imaging. And it's a very good example that we found that, or you found two very important aspects of the underlying pathology with a significant impact of treatment.
Yeah, I strongly agree. And sometimes people say that it is of academic value whether the plaque is fibrous or is it lipidic. But it's not only academic. Of course, it helps you understand your patient, but it also helps you to really tailor the treatment to your patient, and it does have an impact whether it's lipidic or is it's fibrous, because it strongly makes a difference in choosing your landing zone. For example, the sizes of the balloon and the sizes of the stenting, as well as the plaque modification modalities that you can use.
Especially plaque modification.
Yeah, exactly. As far as the assessment of the physiological significance is concerned, of course, we cannot offer that by performing intravascular imaging. But there is a rough approach for this purpose in defining the minimal lumen area, as at least in left main situations. According to the findings of the LITRO trial, there was you can really rely on a MLA in the left main artery at a minimum area of 6.0. In situations where you have an MLA of 4.5 to 6 millimeter square, you should consider physiological assessment. If you have an MLA of below 4.5, then you can proceed with revascularizing. But in non-left main coronary artery disease, you should not rely on those MLAs. Of course, there are reports, but in this scenario, you should. It is recommended to do physiological assessment due to the variations according to vessel caliber and subtended myocardium. In post PCI, what are we trying to achieve? What do we want to see after stent implantation? We want to achieve a stent expansion of at least 80%. So the MSA divided by average reference lumen area, because we know that inadequate stent expansion predisposes to the development of in-stent restenosis or stent thrombosis, and acute malposition increases the risk for adverse events. Post PCI, you should also make sure there is no stent edge dissection or hematoma before finalizing the procedure. This is a very nice case, also showing the use of IVUS. This is a 52-year-old female presenting with acute coronary syndrome. She's been previously stented in the LAD 1 year ago. The echocardiography showed no pathological findings, and the LAD looks quite healthy to at first sight, and I wonder what the audience would really go for in this scenario. Of course, the LAD showed a mild tapering in the mid part after the side branch takeoff. Would you perform FFR in this situation? I think this wouldn't be a mistake. But the angiography is somewhat ambiguous, and we decided to go for IVUS. And very surprisingly, you see a finding. Just briefly, you can see in this left-hand image fairly healthy vessel, some mild calcification, and distally fairly well-opposed stent, then the side branch on 8 o'clock, and a severe under-expansion of the stent, which you can appreciate on the right-hand side. The angiography really did not make you suspect this severe stent under-expansion or malapposition. And in this situation, we made sure that the wire crossing was crossing the stent and not the part between the intima and the stent edge. And we then performed stenting and pre-dilatation with a very nice result, which I did not show you in this scenario. But would you have what would you have done in this scenario? And I mean, the angio really did not show a very pathological finding in a very tight stenosis. So I think FFR or IFR would have fooled you in this scenario, because there was no real stenosis, and there would have not been any other way to find out the pathology underlying this case.
Yeah, I think it's a perfect, I would say, example of a patient where IFR would have been of no relevant use, because, of course, the patient had some kind of ischemia with unstable angina, and but nevertheless, the IFR could have been negative despite prognostic relevant pathology, which could have been only identified with IVUS. And this brings us always back to the fact that in a perfect ideal world, you should use both imaging, or both, it's not imaging, both modalities in every patient, and especially if you have an ambiguous situation. And this is what is stated in the guidelines: you should not use IFR but IVUS to solve the problem, to understand the lesion. And if you understand the lesion, then you can decide in an ambiguous situation if you really need additional hemodynamic information, or, like in this case, that you should proceed, of course, with interventional treatment.
And of course, this is a nice example also, I reckon, for a non-complex PCI situation, because it's been recommended that especially in complex situations, you should be considering the use of intravascular imaging. But this is a very nice example that showing that non-complex situation, because I suppose that this was not a complex stenosis. I cannot offer you the pictures from the primary PCI, but obviously by angiography guided PCI, this patient has been treated in a completely inadequate way, with a very strong and very severe stent malapposition, and IVUS would have helped in this non-complex situation decisively. I would like to show you some more cases of a 56-year-old male. He presented in our hospital with a chronic coronary syndrome, easily recognizable. There's a intermediate long lesion in the mid-LAD. We performed a DPR measurement, which showed a significant hemodynamic lesion with a DPR of 0.81. We did not perform HD IVUS or OCT upfront. We pre-dilated with an NC balloon and then proceeded with stenting with a 3.36 millimeter stent. I guess on the angiography, you can appreciate a very nice expansion of the stent throughout the complete length of the stent. We performed a pot with an NC 3.58 millimeter balloon, and had a very decent angiographic result. And we then very meticulously documented a DPR post PCI with a satisfying ratio of 0.93. But we had some suspicion, because you can maybe assume or sort of recognize on the angiography that there might be some malapposition. But I personally would have not foreseen a malapposition of 0.66 millimeters. The significance of a malapposition is defined by above 0.4 millimeters. So this is a very significant finding. And of course, does this malapposition have acute negative outcome for the patient? I would not suppose, but we have to think ahead. And I think this malapposition does predispose for stent thrombosis, does predispose to restenosis. And IVUS in this situation helped us identify this malapposition and perform another pot maneuver with an NC 4.0 balloon, and achieving a very nice angiographic and HD IVUS results. So another example of a fairly non-complex lesion, non-complex situation. I think we can all agree on that this was a simple procedure, but HD IVUS decisively helped us in identifying a malapposition that you would have not predicted, judged by the angiography.
Estimate the complexity, because we have now two, I would say, very illustrating examples on how easy situations can be made complex if the stent hasn't been placed perfectly. If I was lying on the table receiving a stent, I would not want to be left from the table if the stent position has not been controlled with IVUS. Especially what we've seen, and this is what has been shown in the trials, and the trials in most of the cases always show the truth, is that you in daily routine tend to underestimate the size of the vessels, and thereby you chose in a significant amount of cases a smaller stent.
Yeah, so I would show you some more examples, because I think by showing many examples from our everyday clinical practice, I personally learn the most. And this is in case of a 75-year-old female who obviously had very severe coronary artery disease, specifically of the right coronary artery. There's multiple hazy stenosis, a very tight lesion distally with a true bifurcation, and we then, of course, performed intravascular imaging, demonstrating and identifying a severe calcification of the entire RCA with a 360-degree calcified plaque. Multiple calcified plaques, and of course, in this situation, you cannot move forward and use NC balloons, but you have to consider the use of specific debulking methods. such as rotational atherectomy, orbital, or IVL. In this scenario, due to the length of the stenosis and multiple stenosis, we did not choose intravascular lithotripsy, but orbital atherectomy, as shown on the left. This is a very smooth and a very almost calming procedure with orbital atherectomy compared to rotational atherectomy. It's you have to be patient to in the use of orbital atherectomy when you're only used to rotational atherectomy, but it really has a great impact on plaque modification in calcified scenarios. And on the right-hand side, after the use of orbital atherectomy and already pre-dilating with NC balloons, we have achieved a fairly good result. But after a while, we weren't able to advance an NC balloon in order to optimize our result. And on the left-hand side, you might assume some problem, but we weren't able to really identify why we weren't able to advance the balloon anymore. And we found out in our HD IVUS a severely distorted stent. You see a really chaotic situation almost intraluminally with a severe distorted stent. I guess HD IVUS was not compulsory in that situation, but it did help us identify the nature of the problem, and we were then able to address the problem by dilating this distorted stent and finally achieving a very good angiographic and also IVUS result. So here's another case of an 84-year-old female. We performed coronary angiography pre-TAVR, and on the left-hand side, you can appreciate a significant lesion. It's hazy. There is no real appreciation of a severe stenosis. We performed HD IVUS in this scenario, and on the right-hand side, you see a heavily calcified vessel. There's really no healthy vessel identifiable. A very with a gnarly surface of the calcified plaque, almost no healthy landing zone. In this scenario, we performed specific measurements. On the left-hand side, you see a minimal lumen area of 2.7 millimeter square. We identified the distal reference and the proximal reference diameter, and then chose our debulking device. In this case, we chose another example of orbital atherectomy. I guess in this scenario, it would have been also justifiable to use intravascular lithotripsy by shockwave, but due to the degree of calcium and the thickness of the calcified plaque, we chose to go for orbital atherectomy, and we also were believed that the IVL balloon, in this case, a 4.0 diameter, would have not been able to be advanced into the lesion because the IVL balloons tend to be somewhat bulky, and we achieved a very nice debulking with the orbital atherectomy. We went ahead with pre-dilating with an NC 4.0 balloon. There's maybe a little bit of tapering in the mid part, but achieved a nice result. And then you can see a very nice HD IVUS result with good with good stent apposition. As you might remember, there was a MLA of 2.7 millimeters, and it's very really almost surprisingly good result. I would have not predicted this sort of image post PCI with a minimal stent area of 15 square meters, so a very good improvement of the lumen area. And we would have not been able to choose and really plan our strategy in the same way without IVUS.
Yeah, maybe just one more comment. This, and once again, 2 learning points. I think it was clear that IVUS significantly impacts on the strategy first, and secondly, of course, you see in the first angio a stenosis, but then you can decide on to do additional angiograms. And I would say in most of the, in this case, with this eccentric plaque and the severe calcification, you might not have been able to just estimate the significance of the stenosis. So this is what we do then. We just skip additional angiograms and we just perform intravascular imaging, and then the situation is clear. And this is the reason why IVUS will help in such cases to reduce the amount of contrast. And this is, I would say, a nice example why the guidelines say in a perfect situation, you just need 2 angulations to see the coronaries, and then you do intravascular imaging and or combined with assessment of the hemodynamics, and then you don't need any angiograms anymore, because the rest of the procedure can be controlled by use of intravascular imaging. Of course, we do a final angiogram, but if you take it to, I would say, to the top, you must not do a final angiogram if you have a perfect IVUS result. And this is what the centers do in patients with severe renal failure, that you can spare this if you have a perfect final IVUS.
Yeah, and I think that it's not only the pre-PCI assessment that you have to focus on. Of course, this is crucial before embarking on a stent strategy, but the performance of a post-PCI assessment is crucial, because even if you're the most experienced operator, you will be surprised by some findings if you are not you're not used to IVUS. You have a almost perfect angiography result, but at the end of the day, you might be faced with a significant malapposition. And I think really make sure to check your results not only by angiography but also HD IVUS. And yeah. Okay, so more examples. This is a 76-year-old female with NSTEMI. You can see a very very normal circumflex artery, obtuse marginal branch. The LAD seems to be somewhat diseased, but the ambiguous finding that we had on the angiography was the ostial LAD, which you can see here on the zoom picture. Is this significant or not? Should we perform hemodynamic measurements, physiological measurements, or not? We then opted for performing IVUS in order to check the anatomy of the left main and also the ostial LAD. In the IVUS, we then detected a severe calcified plaque with an MLA of 3.2. As I mentioned earlier, we're not supposed to use MLA measurements in order to judge the significance, the hemodynamic significance. but this situation is a left main like situation. And of course, a significant lesion. The patient had an NSTEMI, so we then did not perform further hemodynamic assessment. On the right-hand side, you see a large discrepancy between the ostial LAD and the left main diameter. And if you look at the left main angiographically, I'm going to go back. I would have personally not estimated the left main to be of 4.5 diameter. So by angiography, you tend to underestimate, as mentioned earlier, the real sizes of the vessel, and therefore we were able to really plan our strategy. We performed pre-dilatation, we performed stenting, KISS, and final pot with a 4.5 by 8 millimeter NC balloon, and had a very nice angiography result. And last but not least, in the HD IVUS. So in this particular case, you can appreciate the importance of performing pre and post PCI assessment. Yeah, I would like to hand over to Christoph Hammerstingl to conclude the session.
Yes, thank you very much, Alexander. I think those were very clear cases with perfect messages depicting, I would say, the most important aspects, how and when to use intravascular imaging. And I just, before we conclude, or before I conclude the session, I want just give you a short glimpse into the future, what could be done to make it even more usable in daily clinical routine. This we were able to have the opportunity of co-registration of HD IVUS with angiograms, and you see how it can be performed here. You just have to draw a center line. In your coronary, you need 2 angiograms with a certain angle in between the 2 angiograms. And then you have a 3-dimensional model of the coronary artery, and this is calibrated to the HD IVUS. And if you do a co-registration, this is all you need, that you can, I would say, travel around this coronary, and you see simultaneously where you are in your coronary and what you see on IVUS. And this is extremely helpful because it's at the end, it has the opportunity to spare time to see where the narrowest lesion, to do your measurements and so on, to measure perfectly the length of the lesion, to estimate calcification and so on. And this could be the perfect future of a combination of with a combination of angiograms with HD IVUS, with this co-registration. And at the end, it can be useful to make the situation even more simple in clinical routine. This is always the discussion that we have if it comes to imaging, or if it comes to advanced imaging, that of course it takes 2 or 3 steps. And then somebody says, yeah, but this is time consuming. Of course, you must take 2 or 3 steps, but at the end, it's time saving, because you have just 2 angiograms, you have 1 IVUS pullback, and then you have every information you need. You just travel along your vessel, and then you can plan your strategy, and that's it. And then you do your intervention, and at the end, you can control the PCI afterwards with HD IVUS, and that's it. So of course you have to add 1 or 2 steps, but by the same time you can skip 2 or 4 other steps or angiograms. And I would say the bottom line is that it saves time and it increases safety and optimizes all the results that you want to achieve. So to summarize the session, of course, the prognosis of coronary artery disease is determined by a variety of factors, and not only an angiographic picture. I think this is what we learned over the years, and which is already clear. Coronary angiography maybe identifies simple lesions, but I would say it can help to identify very tight lesions that are at need for treatment, but it has, at least in complex situations, a significant limitation, and it can hide the truth. And if complexity increases, there's a relevant need for intravascular imaging. It's important in daily clinical routine to develop a routine workflow for, I would say, complex or non-complex lesions, including intravascular imaging and or the measurement of hemodynamics. And you will see that if you implement this routine workflow, you're speeding up really fast in your daily clinical cases. You should or you must focus on pre-specified key questions which have been clearly defined by our guidelines, and the use of imaging is very important early during the procedure. And I think the study that we showed was very impressive, that the use of imaging, of intravascular imaging, is even more important in non-experienced interventionalists. And I think it's very helpful to understand the morphology, the pathology, and the anatomy of the vessels to choose then your treatment plan, your strategy, how to not only to help you to decide how the diameter of your stents, but even how long it should be, where you want to place it, how you want to place it, if there's a significant need for lesion preparation, and so on. I think we showed some very helpful examples. And it can be very helpful in patients at high risk for renal failure due to contrast dye. You can significantly lower the volume of contrast during an intervention. In extreme cases, you can completely avoid the use of contrast. It's an investment into safety and outcomes because the data are clear. And I think if we use it in daily clinical routine, and you will see it, that this investment is not only, or this statement is not only true in complex situations, but especially or also in non-complex situations. I think we just have to wait for the data to be published, but it's clear, and we see it in daily practice. We just showed you 2 cases, this relevant underextended malposition of stents or underextended stents. And therefore, to our opinion, intravascular imaging should become standard of care in modern PCI. Currently, we have a class 2A indication, which will change, I would say, in the future, because the guidelines are from 2018, and we have some new data out there that will help to improve this guidance, and to add new evidence on the use of intravascular imaging. So with this, I want to conclude our session, and I want to thank you very much, especially Alexander Volz, for the preparation of most of the presentation, for the excellent presentation of the cases that we treated in our hospital, or that he treated in this hospital. And we are very happy if someone of you wants to send us questions. We would be happy to share our experience with anybody who is interested in the use of intravascular imaging, to share our experience how to implement intravascular imaging in daily clinical routine. I think it becomes clear that we are great fans to use it in almost most of our cases. And I think you have seen that even in some cases where we started with a conventional approach, we somehow switch to intravascular imaging, especially if there's an ambiguous situation and we want to have a perfect result in our patients. So anything to add from your side, Alexander?
No, thank you very much. It was a pleasure to be presenting, our that we are big fans of intravascular imaging, and I think no one should be afraid of performing HD IVUS or whatever intravascular imaging modality, because it really is no rocket science, and it's easy to perform if you have developed a very smooth workflow. It does save time. It doesn't take long. It does save material. You don't have to use 10 different balloon sizes. You really are able to plan your strategy well, and it's no eyeballing medicine anymore. I mean, we were all used to eyeballing, and we tend to do eyeballing, and it's not state of the art anymore, I believe. Of course, there are scenarios where you can do not have to perform HD IVUS in 100% of your cases, but please be free and use intravascular imaging more generously. Of course, the cath lab assistants have to be involved in this process. You have to really advertise this treatment, but I believe that the modern PCI will not be able, or well, it's not possible to really not use intravascular imaging in modern PCI. So it was a pleasure, and thank you very much to Radcliffe Cardiology and ACIST, and to you.
If we think about the use of IVUS, I think we addressed several important aspects that maybe could solve some problems about the costs. And of course, it's not time consuming. It can help to save contrast. But maybe some restraints could be due to the fact that there's a fear of increasing complexity and thereby increasing complication rates by the use of intravascular imaging, especially in patients that are not at need for intravascular imaging, because of course you have to go to the vessels. And I did not remember any case where we had a significant complication due to the use of IVUS in any patient, even if we excluded the need for treatment. Do you remember any situation, or can you think about a situation where IVUS can add complexity and thereby increasing interventional risk, Alexander? Maybe you have some thoughts about this.
Well, I think that's a very important point, that there might be some people having in mind certain complications caused by the introduction of the IVUS probe. Of course, whatever device we introduce into the coronary artery, we have a certain risk of complicating things. But in my personal experience, and the data shows that very well also, there is really an extremely low probability of causing complications by the introducing the IVUS probe. It always depends on the device that you use. The device that we use is the Kodama ACIST device, and it has a tip entry of lower than 1.7 French. It's very nicely deliverable. Of course, there are scenarios. I would not suggest you to introduce the IVUS probe, for example, in a very tight stenosis in the proximal LAD or in the left main, where you are afraid of occluding the vessel. In those scenarios, I would suggest to first pre-dilate cautiously and make some space for the IVUS probe, perform your IVUS, and really, at the end of the day, it is not ruled out that by introducing the IVUS probe, you might cause some vessel injury. But really, in my personal experience, and not only my personal experience, but the data shows that it's a very safe procedure. So I don't think that this is a problem in the majority of the cases. So we hear people having that in mind, that we do not want to disrupt or erode the vessel, the intima. But I don't think that is the case. On the other, it's the total opposite. It's an investment into the safety of the procedure, and at the end of the day, in improving the outcome of our patients.
Yeah, I think it's a clear message that the net clinical benefit is absolutely pro IVUS, and on the opposite, there's no reason to avoid it, because, like you pointed out, the probe that we are using is really atraumatic, and there's no reason to avoid this situation.